It's a real pleasure to be here, and I want to thank the organizers, Mark, Amy, who's not here, and Melanie, for actually conceptualizing this and making it happen. Elaine Faustman is someone I've known and admired for years. Wanted the opportunity to work with her on some of the things that we wanted to start here in California. And now we're hoping that this is the start of a West Coast consortium, not just Bay Area, but West Coast in terms of the ways in which we can pull together information and really extend that by these kinds of collaborations. So I want to talk about something that is very important to me, near and dear to my heart. I started out as a cancer epidemiologist studying adult cancers for over 20 years and became very concerned about 15 years ago that the epidemiology of childhood cancer really wasn't advancing at the same pace that our knowledge about adult cancers, and particularly for a variety of risk factors. And it was at a time when molecular epidemiology was just beginning, or 15, 20 years ago, getting to people who were saying, this will help us improve the way we do epidemiologic studies. And so we designed this study here in California to incorporate the use of a lot of biomarkers so that we could indeed get better insights in terms of exposure and the disease process, focused on children's cancers. So let me start, and I just want to mention that this particular picture is an oil painting by a really outstanding UK artist, Susan McFarland, who was commissioned to do a whole panel of paintings about the process of diagnosis and treatment of children with leukemia. We have copies of this in our research office. Those of you who are going to join us this afternoon for some discussions about further collaboration, we'll see the whole series. They're very large. I had an opportunity to see them on one of our research meetings in London, and they're about as, half the size of this screen. They're very dramatic and showing the parents there with the children, showing the research investigators at different stages of diagnosis and treatment of children with leukemia. And it was an effort to bring the humanities to medicine, to help to bring the human element into treatment, diagnosis, and treatment of childhood leukemia. So why bother studying childhood leukemia? Compared to adult leukemia, it's a very small proportion of the burden of disease. But when you think about in terms of the years of life lost for a child who dies of childhood leukemia at the age of 5, there's a deficit in terms of years of life of 65 to 70 years. So it's very important to be paying attention to diseases in childhood where we can talk about prevention. For childhood leukemia, we've had dramatic results in terms of treatment, where I think 25 years ago, a child with a diagnosis of leukemia, the majority of them would die within 2 or 3 years. We're looking at survival of maybe 30%. Now we can talk about close to 80%, 80 to 90% of children. We can actually talk about cures for 75 to 80% of children with leukemia. But the issue, though, that we face with all childhood cancers is there are some sequelae from the treatments that are used. Chemotherapy, radiation, radiotherapy, they leave a mark. They leave either cognitive disabilities or physical disabilities from the treatments themselves, and with chemotherapy, second primary cancers. The risk of a second primary is very high. So it's very important to really talk about prevention. We work with an outstanding network of pediatric oncologists, and now that we have the center in place and Mark Miller is working with us, it's so interesting to see how the clinicians that we're working with really do understand the importance of prevention, and now Mark is working with them to take a better environmental history, maybe just to take an environmental history, because the environmental history, similar to what's been done in the past in terms of adult cancer, is very cursory. They might ask, does anyone smoke? They might ask, what does, where the father works. But to get a good environmental history takes a lot more attention than that. But when we started our study now in the mid-90s, very little was really established in terms of causes of leukemia. What we did know could only explain less than 10% of the cases. The list of, and some of the established causes are listed here, but that would explain such a small proportion of the cases. But the list of suspected agents was very long. And the methods that were being used were really the black box method in what we call the black box method. Ask about exposures and then just try to correlate that with the risk of disease without paying attention to different biomarkers and different mechanisms along the way. Catherine already pointed out one of the very unique epidemiologic features of, is this the pointer? I can be advanced here and show you. One of the very unique epidemiologic features of childhood leukemia, where we see the difference between ALL and AML. This is in the dark over here, I apologize for that. The red line is acute lymphocytic leukemia, and the green line, or lime-colored line here, the myeloid leukemias. The majority of leukemias in children are lymphocytic, 80%, approximately 80%, and then around 15% the myeloids, but they have a very different age pattern. And so you see this particular peaking between the ages of 2 and 5 for the lymphocytic leukemias, which really is a clue, an epidemiologic feature that suggests the importance of early exposures for these particular types of childhood cancers. As a cancer epidemiologist, I've been very interested in what do we know about causes of cancer in general. And if you look at this pie chart here, and again, these numbers aren't very helpful, but at the top of the list in green is tobacco. And we look at all cancers, and this is by the Harvard Center in 1996, not unlike what we were looking at in the 1980s in terms of 1/3 of all cancer incidents, and also paralleled by mortality associated with tobacco exposures. And then we're looking down here at red, diet, and physical activity and obesity in red, and then a portion to all of these other causes, approximately little more than 1/3. Recently in the UK, Parkin and Associates, using IARC type approach, but using UK data, updated what was known in terms of the proportion of cancer associated with different exposures and attributed to these various exposures. So here, what we're seeing again is tobacco, very dominant in this list. Now, most of these cancers are adult cancers. Childhood cancer, fortunately, is rare, and if we look at the total cancer burden, less than 10% of cancer would be associated with cancers before the age of 14 or 15. But then we see diet, then overweight and obesity in second place, and then the other exposures. This is similar to an analysis that was done 2 years earlier in France using French data. So that the lineup in Western European countries and in the US is very similar in terms of the importance of tobacco for cancer in general, tobacco exposures. And we're talking about, when we talk about tobacco, I'll go through some of the exposures in this very toxic mixture, what we refer to as tobacco smoke. But earlier I suggested to you we were going to move out of the black box where we correlated exposure with disease, and we weren't paying attention to what was happening in this inside the box. And this is the box. This used to be the black box. We've opened up, we and many people. And Frederica Pereira was one of the very first people to really push this concept in environmental epidemiology very successfully. And many of us have embraced that, where we look at, we use ways to look at biomarkers of exposure in terms of internal dose. Here, this example would be DNA methylation, biologically effective dose. Here, DNA adducts, biomarkers of early effects. Here, we're looking at different types of translocations, chromosomal translocations, like the tail AML translocation that Joe and Catherine were talking about. And then throughout this whole process, it's influenced by genetic markers of susceptibility. So it becomes much more complex, and the more we learn, the more complex it becomes. Cancer is not a dull subject in terms of trying to understand causes of cancer. So I'm going to focus on where we are in terms of parental smoking, maternal and paternal, and why this is such, I believe, the data now suggests this is such an important risk factor for childhood cancer in general, but childhood leukemia specifically. I was on the, this is the, as a background in terms of smoking and health, this was a landmark report in the United States when the federal government took on the task of beginning to document the fact that tobacco smoke was an established carcinogen and pulled together the data. It took until 1986 for the International Agency for Research on Cancer. Now, that agency came into being in 1966. With the Surgeon General's report in 1964, one would have thought that IARC might have had this, whoops, is this too close? Okay, good, thank you. One might have thought that IARC would have this higher on their priority list, but it took until either 1983 or 86 for IARC to publish their first monograph on tobacco smoke. We now know that based on the updates on tobacco smoke by IARC in 2004, and then the most recent one in 2010, volume E, which has not been published yet, but the early results of that have been summarized in the in Lancet Oncology. But we now know that there are many cancer sites associated with many cancer sites in adults associated with tobacco smoke. The list is quite long, includes liver, kidney. The breast is still, according to IARC, in a category of possible. For me, the important thing was in those reviews, I participated in both of them. In 2004, for childhood cancer, the results, for leukemia specifically, but childhood cancer, the results were inconsistent. But in the 2010 review, the results for hepatoblastoma, a liver cancer in children, were conclusive. There were 4 studies that showed very strong association, and it's consistent in terms of the importance of the developing liver in a child being exposed to this complex mixture of carcinogens. For childhood leukemia, the results were suggestive, and those are the results I'm going to go through because I think now, that was the data we were working with were 2.5 years ago, that was 2.5 years ago. The results, I think, are much more persuasive with what we know today. I emphasize this because here's a preventable or avoidable cause of cancer. Children are exposed in terms of secondhand smoke. Children are, a alarmingly high proportion of children are exposed to secondhand smoke. But let's take a look at tobacco smoke. I've listed here, I've said this is a complex mixture, thousands of compounds. here are agents that are carcinogenic, and they include, here we have the PAHs, 10 of those, 6 heterocyclic hydrocarbons, 4 volatiles, 3 nitros. It's an impressive list. We should be paying attention to it. Still today, you can be in an environment where maybe a parent lights up their cigarette with a young child sitting on their lap. Not in a public place, or most public places, but you still see it. So there's a lot of education that needs to be done. Secondhand smoke. The mixture for some of the compounds, the exposures may be higher to some of those compounds in secondhand smoke. The data that we put together for the 2010 IARC report, and this was worldwide, established that between 20 and 70%, with an average of 47, of children are exposed to secondhand smoke, depending on the country and socioeconomic status. So this is a really ubiquitous exposure, even in a state like California, where we've been very progressive in terms of reducing the potential for exposure. But we would still see 20 to 30% of children exposed to secondhand smoke. I've already mentioned the reasons to be concerned in terms of the mixture, and then the secondhand smoke was classified as a known human carcinogen by IARC in 2002. It was the 2004 report, but the announcement was in 2002. The studies of children, as early as 1994, IARC was arguing that the cancer risk from secondhand smoke, specifically to young children, have not been adequately characterized. I agree with that. And when we were designing our study in 1995, it was very interesting. Probably one of the world's leading cancer epidemiologists told me, who was an advisor to us in our study, said, "Pat, don't worry about paternal smoking. It's the maternal smoking." One of the world's leading cancer epidemiologists. I probably shouldn't name him. But then my colleague Bruce Ames on the Berkeley campus came to me, who was also an advisor, and I was part of his Superfund, or his environmental health center at the time. And he was looking at our questionnaire and reviewing the study with me. And he said, "You have to ask about paternal smoking." We had already started the study. We had finished 92 interviews. And I said, well, my cherished colleague, world-renowned cancer epidemiologist says no. And then he showed me the data that one of his postdocs had put together showing aneuploidy in sperm associated with cigarette smoking. And this is biologically active. We should probably pay attention to this. So we added, that's why on some of our data, we have fewer responses for paternal smoking than maternal. So we changed that, and we added it. So then in 1999, very important study that came out of the Columbia group, reported that there was a small sample of minority children, Hispanic and African American, in New York under 6 years of age, that those exposed to secondhand smoke had higher levels of the 4 biomarkers that they were looking at, 4 biomarkers of tobacco exposure. Cotinine, of course, protein adducts formed by carcinogens, the 4 aminobiphenyls and PAHs, and sister chromatid exchanges. Very striking, the difference between children exposed and children not exposed. I'm going to move on to our data and our approach, and keep me on time, Mark. Here's what we're concerned about: preconception in terms of germ cells. We're concerned about pregnancy in terms of the fetus, and the early years. We focus on the first 3 years, that prenatal period. And we ask most of our exposure-related questions are looking at preconception, during pregnancy, and postnatally. If we look at applying this to tobacco smoke, preconception, both paternal and maternal, During pregnancy, the mother, but the father might also be smoking, and then postnatal, everyone in any exposures in the household. Now, in order to understand secondhand smoke and tobacco smoke directly, we have to understand, in terms of the child's exposure, which are secondhand and which are direct. If we look at, here's conception, here's birth, in this line, maternal, and then prior to conception, maternal smoking would be direct in terms of germ cell. During pregnancy, direct in terms of the fetus being exposed. The fetus would be exposed to just what the mother's exposed. It's not secondhand. And then after birth, it's secondhand in terms of maternal smoking. For paternal, preconception, it's direct. During pregnancy, it would be secondhand. Mother's not smoking, presumably. So it's secondhand exposure, and then postnatally. And then for others in the household, it's all secondhand. Okay, our first look at this, one of my absolutely wonderful doctoral students, Jeffrey Chang, took this on in terms of analyzing the data we had from the first phase of our study. And we found some really impressive associations, particularly with paternal preconception exposure. There are a few studies in the literature that suggested this might be important, which is why it was important to take a look at it. But the data were inconsistent. And when we looked at this in terms of timing of exposure, father, yes, no, mother, preconception, pregnancy, these are how we collected the data, and this is how we were able to analyze the data. And then looking at it for the B-cell lymphocytic leukemias with our most recent data, 657 cases, not all of the recent data, but updating the publication, you can see for the paternal preconception with number of cigarettes per day, over here, it's in the dark, where you have a increased risk, which is consistent with statistical significance in terms of that lower limit being above 1 on the confidence interval. And then where you look at any exposures after birth, down here, this odds ratio, which is hard for you to see, I think, is 1.32, and the lower limit, again, is consistent with statistical significance. Now, one of the things that we certainly came to grips with in looking at our own data, but also looking at the published literature, because there were now, at the time we were doing this review, let me move back a minute, several cohort studies, large cohorts from the Nordic countries, but many case control studies. And one of the things we know about maternal smoking during pregnancy, number one, the rates have been driven down, so that in our cohort, okay, moving along, our cohort, our California study population, less than 10%, around 8 to 9% of our mothers reported smoking during pregnancy. But you also know from the epidemiologic literature that tobacco smoke is associated with maternal smoking during pregnancy is associated with a high rate of spontaneous abortion. And the spontaneous abortions are marked by chromosomal aberrations that are incompatible with life, multiple chromosomal aberrations that are incompatible with life. So that in a case control study, those fetuses that are impacted, those fetuses to smoking mothers that are impacted by tobacco smoke may be lost. A high proportion of them will be lost. So that a case control study is a difficult way of studying maternal smoking during pregnancy because of number one, low exposures, but for the women exposed, you're going to not be able to pick up those fetuses that might have been impacted and go on to develop childhood leukemia, which is also associated, as Joe's work illustrates, by these types of chromosomal aberrations. With regard to TEL AML, it's compatible with life, but it's a risk factor for childhood leukemia. Oh, now let me move on in terms of the joint effect of smoking. One of the things that we found in our data, and there's evidence in the literature of with some of the other studies, that it's not just maternal or paternal smoking, but the joint effect, and it's a cumulative effect in terms of time and level of exposure. So if you look here in terms of father's preconception and then any smoker after birth, it's when we see that combined, that joint effect, that we see the 50% increase in risk compatible with statistical significance, if you look at that confidence interval. The first meta-analysis that looked at this, done by Lee, or this was done by Kang, included our study, the Chang study, and some of the early studies that had reported on this, the John study notably, but with a very small number of cases. And that's the size of the study population would be indicated by the size of the dot there, the bullet. But the overall, for all leukemia and lymphocytic leukemia, the meta-estimate shows a odds ratio here of 1.12 and 1.17, both of which are consistent with statistical significance. So this was in 2008, really remarkable statement pulling these data together, because these results, so you can see the variability, you can see the inconsistency, and you can see why it's been difficult to pull a story together in terms of being able to speak to this as a risk factor. A recent analysis by one of our Berkeley graduate students working with Kathy Hammond updated these analyses. Impact of paternal preconception on childhood leukemia. This is paternal preconception. Our study is shown here, and the meta-estimate is shown here, and 1.15, consistent with statistical significance and consistent with the earlier Chang analysis. This just includes more studies. Then looking at during pregnancy, paternal smoking, again, focused on the father, we see, again, 1.25 and consistent with statistical significance. And then after birth, borderline significance, but also elevated, 1.25. Let's move on then in terms of our data, looking at our data by cytogenetic subtype. And Joe pointed out these two major types in terms of a structural abnormality, TEL-AML, that translocation that was very common in the 2 to 5-year-olds, 25%, and then hyperdiploidy, which we see in over 30% of our cases. All of our cases are under the age of 15. We see in terms of the etiology being associated with these different types, very different pattern. With hyperdiploidy, the results are really flat. With TEL-AML, we see significant associations when the data are looked at for different time periods and by paternal and maternal, emphasizing the importance of these molecular subtypes of disease in terms of providing us with clues to etiology. Then looking at the joint effect on B cell that have this particular translocation, we see with the preconception and then the postnatal exposures, a 2.4-fold increase, consistent with statistical significance. And then important to look at AML, and we hadn't had enough, we hadn't had enough cases until recently to really pay attention to the myeloid leukemias. Those of you who've paid attention to leukemias know that the majority of adult leukemias are myeloid. These are the leukemias that are associated with benzene. The most important exposure in tobacco smoke is benzene. So we now had 145 cases, so we were able to look at this, and here you see 1.49, borderline significance, but certainly impressive based on a limited number of cases. I'm going to move past this slide because I've already talked about that. Just to make the brief conclusion about the risks, that the associations that we see with risk, that they vary between ALL and AML. They vary between B cell and T cell ALL, and that the leukemias with this particular structural abnormality, the most common, the TEL-AML, versus hyperdiploidy. We see the difference in terms of the importance of the molecular subtype. I'm now going to talk briefly, 1 or 2 minutes, about an important part of our new center, which relates to what do we do with findings where we've got low-level effects, we're constrained by sample size, and we know that people around not just around the country, but around the world are looking at the same associations and are struggling with small numbers. So we put in place what's referred to as the Childhood Leukemia International Consortium, a group of investigators, now numbering 14 to 15 different investigators with over 20 studies in different parts of the world, to work together. This is a map showing where we are. This is now up to 24 studies in 14 countries. But we started this consortium in 2005, 2006. It's now progressed where it's a very successful consortium, and we have in place the procedures for pooled analyses, two of which are going to be looking at tobacco smoke. And with these studies, we are now looking at having more than 6,000, close to 8,000 cases with genetic data and a larger number of controls, so that we will have the numbers where we'll be able to look at the ALL, AML story, not just for tobacco smoke and its exposures, but for other exposures that we believe may be important. The benzene-related compounds, where we will be paying attention to benzene, not just in tobacco smoke, but benzene in household products like paints and solvents, and benzene associated with fathers' and mothers' occupation, because we do obtain detailed occupational histories. Then I've mentioned pulling together these data and the reasons for this consortium. And the consortium also helps other groups in Japan, Guatemala. We have other groups in other countries that are wanting to start studies. So we invite them to join us as associate members and work with them in helping them design case control studies to do something similar. I want to acknowledge how's that, Mark? Our collaborators. We're very pleased. This is probably not a complete list. Very pleased to have such an outstanding group of collaborators and collaborating institutions. And then, of course, our hospitals and sponsors, as mentioned by Catherine. We've been very pleased, really fortunate to have continuous support from NIHS for the last 15 years. Very excited about being named as one of the newest, I guess, childhood environmental health centers. The first one on cancer. I guess when they started those centers, they said, no, we're not, because I did ask, we're not interested in cancer. But if you ask parents about what their concerns are with regard to their children, parents are really concerned about cancer. So I'm glad that they expanded the program. I'm glad to be a part of it. So thank you very much.